My topic is Pick Me Up, Fill My Cup, presenting on behalf of Medicine 2. Presenting 24-year-old lady, she is a graduate from Bangladesh. She has presented with complaints of episodic sudden onset weakness of all limbs in the past 8 years and progressive weakness of all limbs the past 5 years. Generalized body pains for the past 3 years, dryness of mouth and eyes in the past 3 years, as well as loss of weight and appetite for the past 3 years. Some relevant history of presenting complaints. Episodic sudden onset weakness of all limbs. She had 2 episodes which were sudden in onset. Within hours, it has progressed to all the limbs. It was severe, requiring hospital admission, and it was relieved in 3 to 5 days with the injection administration in the hospital. Coming to progressive weakness of all limbs, it is symmetrical loss. All the 4 limbs were involved. Initially, she was able to do her activities of daily living well, and then she needed support, and then she needed support for even standing, and then it progressed to sit with support, and currently she can sit with minimal support and she is bedbound for most of the time. But she is able to mix food, but she is not able to comb hair. And generalized body pains for the past 3 years is been almost consistent and constant. Dryness of mouth and eyes for the past 3 years. Significantly, she has complained of dryness of mouth. She needs water to wet her mouth multiple times, and when she wakes up after sleeping in the night, she feels mouth is very dry, and occasionally she has also noted that there is ulcerated mouth and mild bleeding after waking up. She has also lost significant weight of 11 kg in the past 3 years, and there is loss of appetite also. Other relevant history we have asked for is that there was no features suggestive of hyperthyroid state like palpitation, heat intolerance, vomiting, diarrhea, alcoholism. There was no diurnal variation in the weakness of the limbs. There is no fatigable weakness. There was no sensory loss, no drooping, no dysphagia, no pain at rest, no Raynaud's phenomenon, no swollen or red joints, no morning stiffness, no rash over face, knuckles, chest, and no features of fever, melena, chronic vomiting, diarrhea, repeated infections, TB, contact of TB. Her menstrual history, bladder, bowel history were normal. There was no history of addictions and drug intake, tobacco, ethanol, or alternate medicine intake. She has been diagnosed with hypothyroidism for 3 years on 100 microgram thyroxine, which she is taking. On her compliance is good. Treatment-wise, she has been non-compliant. She has been prescribed many medications by many physicians. She has been consulting. Occasionally, she used syrups. For the last 6 months, she has been only using paracetamol and thyroxine. There was nothing significant in the family history. On examination, her height was 158 centimeter with a weight of 26 kg, BMI of 10.4. Well, very emaciated appearance. Few oral ulcers noted in the molar area. No palpable lymph nodes, no spleen or liver palpable. No pallor, icterus, cyanosis, clubbing, or lymphadenopathy or edema. Vital signs were normal. Her cardiovascular respiratory examination was normal. Abdomen was also normal. Central nervous system examination, higher mental functions, cranial nerve examination was normal. In the motor examination, bulk bilaterally symmetrical. There was wasting present in all the limbs. And the tone was normal in all the limbs, but the power was reduced. The proximal muscles power, upper limb and lower limb were 2/5, whereas the distal muscle was 4/5. The reflexes was normal, 2+ in all the limbs. Plantars were both flexor. And the sensory examination, it was normal for pain, temperature, touch, position, and vibration. Cerebellar and meningeal signs were negative. Skull and spine was also normal. Musculoskeletal examination, there was tenderness present all of the limbs. There was no specific site, but all of the muscles over the bony areas, tenderness was there. When we looked into the particular synovial points, there was no synovial tenderness more in compared to the other points. There was no swelling or joint or redness in these points. No deformities or masses, but she had felt painful movements in all 4 limbs while she is actively moving. The passive range of movements have been full, and also we have found that her Trousseau sign was positive. The end of clinical history and examination, there is episodic motor weakness predominant and progressive motor weakness, proximal more than distal, with progressing body aches with loss of weight and appetite, dry eyes and mouth, and oral ulcers. Overall, there is clinical impression as that of multi-system involvement. Musculoskeletal predominant is evident. with constitutional features and Zika symptoms, and we also suspected endocrine electrolyte involvement. Putting things again into perspective, here we have considered a dyselectrolytemia with the hypo and hyperkalemia, hypocalcemia. And in the differentials for periodic paralysis, unrelated to exercise, it was not related to fatigability or exercise at all. So we have considered hypokalemic paralysis. We also considered RTAs and thyrotoxic paralysis. And progressive proximal myopathy, again, endocrine metabolic myopathies were considered. Again, here we have considered hyper and hypokalemic periodic paralysis, osteomalacia because of severe tenderness, weakness, and thyroid and parathyroid abnormalities, and malignancy and bloodborne viruses, idiopathic inflammatory myopathies were also considered, supported by her features of Zika symptoms as well as oral ulcers. And other specific autoimmune or connective tissue disease, will put Sjogren's syndrome in the beginning, as well as other autoimmune conditions like SLE, RA, which can cause RTAs. And osteomalacia, if we consider it on the top, and under the osteomalacia, vitamin D resistant rickets, CKD, RTA is considered. Other conditions in general, systemic hypothyroidism, disseminated infection, malignancy for the constitutional symptoms. Here, the highlighted bold items, there are a few things which are overlapping into each of the clinical setting. The periodic paralysis, progressive myopathy could be explained by the hypokalemic periodic paralysis, and osteomalacia could be explained by the RTA, and RTA explains periodic paralysis as well. So there were things which are overlapping which could explain each other. Initial evaluation had shown metabolic acidosis and normal anion gap, and there was hyperchloremia of 116, hypokalemia of 2.2, and the CBC picture was normal. The other significant things we have found in the lab investigations: hypokalemia 2.6 with bicarb of 6, and phosphate was 2.4 low, and calcium was low normal 8.76, and alkaline phosphate was 453. And urine analysis had shown leukocyturia, but here was asymptomatic, and pH was 7. Chest X-ray, when he looked in the initial investigations, normal lung and heart, but the bones showed osteopenia. Initially, we had done CPK, which was normal, LDH was higher normal, and thyroid functions and ECG were normal. These are the X-rays where we can see there is increased translucency in the ribs. There is increased translucency in other bones as well. And if we can see closely, there are transverse lines which are sclerotic and more dense, which are transverse to the cortical bone. They are not very well obvious, but if we look closely in this tibial bone, we can see those are classically which can be grouped into this looser zones, where there is a sclerotic bone along the vessel vessel. When the vessel enters the bone, and when there is condition like osteomalacia, there is sclerosis forming looser zones. And we had further investigated in the autoimmune panel as well as the electrolyte panel, which I will explain further. Here we had considered hypokalemia, and considering that she had required hospital admission and there was emergency, and she had significant clinical setting, she had required emergency as well. And when we had examined her, there was a definite muscular weakness and progressive weakness. And the initial urine potassium, which we have done, has shown higher value. This is the algorithm from Harrison's, which shows when there is a hypokalemia with a high urine potassium value, we are considering renal losses. And there is an entity called transtubular potassium gradient, which measures the difference between the cortical tubules, how much potassium is in the collecting duct compared to the peritubular vessels. And when we have calculated this using the urine potassium, urine osmolality, serum osmolality, we have come to a value which was 7, which was higher than 4, and that points to a distal potassium secretion. That means more potassium is secreted and is being excreted. And the next algorithm says we'll check for BP and volume status, which were normal for her. And so we come to the left arm of it, where we see the acid base status, and she was in metabolic acidosis. And we have narrowed down our differentials to metabolic acidosis, which then the causes could be proximal RTA, distal, DKA, amphotericin, and stazolamide, which are main causes. She has not taken these drugs, and her sugars were normal. She is not a diabetic as well. And we have come to a narrow diagnosis of proximal RTA, distal RTA, causing her periodic hypokalemia. This is a simple algorithm given in Journal of Nephrology in an article where there is a normal anion gap metabolic acidosis, and we suspect a renal tubular acidosis when we sufficiently exclude extrarenal losses. We check for urinary pH first. When it is above 6.5, we check for serum potassium. When it is low, there is a very high chance of being distal RTA. This was the case in our patient when we did our investigations. And also we had done the workup for the most probable causes of distal RTA, out of which the initial autoimmune conditions, Sjogren's is the one. And she had also presented with dry eyes, dry mouth as well, and her SSA was positive. So distal RTA, these are the causes listed, out of which autoimmune conditions. In the autoimmune conditions, Sjogren's comes the first. Diagnosis is as follows. There are 3 clinical things as well as 1 histopathological and 1 serology. Out of the 3 clinical things, these are cylometry, where they check for saliva. The patient has to spit out saliva, after which, after 15 minutes, without any stimulation, saliva is collected and is measured. Second is the Schirmer's test, as we know. Third is the ocular staining, which measures how much tear film is there in the eye. If any of those things are positive, plus 1 antibody or salivary biopsy, which is showing lymphoblastic sialadenitis, Sjogren's syndrome diagnosis is made. At the same time, we have to exclude the other conditions which can cause a distal RTA, which can mimic these things, such as hepatitis C, AIDS, sarcoma amyloid, and IgG4, and any radiation therapy prior. So another point which I want to add on is this. This is an article from CMC itself. 31 patients who were presented with hypokalemic periodic paralysis between 1995 to 2001. They have studied what is the etiology of the hypokalemic paralysis. 13 out of them had RTA, and out of the 13, they had seen that 10 of them had proximal, whereas 3 had distal, and out of this 13, 3 had Sjogren's syndrome. When we calculate 3 out of 31, that is almost 10% of the hypokalemic periodic paralysis had Sjogren's syndrome, whereas the other causes were hyperaldosteronism, thyrotoxic periodic paralysis, sporadic periodic paralysis, Chiltern's syndrome. So in this patient, when we look back, we notice that she has been ill for a long time, but without a etiological diagnosis, for which she had developed osteomalacia as well, and she had become bedbound, and she has her burden of disease has become more. So currently, working diagnosis, hypokalemic paralysis with osteomalacia, secondary to renal tubular acidosis with primary Sjogren's syndrome. We have done a salivary gland biopsy as well, and shell evaluation with complete tests to be done. She was started on potassium supplement, bicarbonate, hydroxychloroquine because of a major organ involvement, and vitamin D, calcium, phosphate, and thyroxine is continued. Take-home points, when there's a patient with hypokalemic paralysis, that is the best time to evaluate for the etiology and to treat the etiology. And secondly, osteomalacia occurring in Sjogren's with RTA, it has been reported in few cases, and it is not a very common finding, but because RTA was not treated at right time and it has progressed, and osteomalacia could be a secondary to the RTA, secondary to Sjogren's syndrome. Thank you.
I think we have overshot time, so I think we're close now. Thank you everyone for presenting. Just few things. Stick to one point in your presentation and stick to time. I know we started late today because of technical delays, but stick to time. So today's we had quite a lot of interesting presentations, but today's presentation I'll give to Ahikam for the best presentation.